Welcome to the VMR on Thursdays. Robbie and I are so excited to talk some medicine with you all. As always, we can't do this without you, and it's just so much more fun with you. So please volunteer a case, volunteer to discuss, and have fun with us. Put your names in the chat. And as always, we're still looking to hear from you all, get some more feedback about the podcast, VMR, all so we can keep improving our products. So just put the feedback form again in the chat. If you haven't had a chance to fill it, we would be eternally grateful. And I'll be passing the mic to the one and only Robbie M. Jiha, and he's going to tell the story how he is not the one and only Robbie M. Jiha.
Man, yo, wow. I've never had a pause before. You know, like you're like the one and only pause. Ooh.
It makes it more powerful, right?
Yeah, it's very dramatic. It's much harder to make a counter argument to one and only pause as opposed to one and only. Wow, that was inspiring, yo. I'm learning a lot from your what's the fancy word? Oratory? Check me on that.
ESL, sorry. Can't help you with that one.
I think I count as E5L or something. But anyway, oration. Oh, Alec to the rescue. Oof, always. Hello, everyone. It's great to see you all. I say that quickly, but that doesn't diminish the true sentiment. I'll say it slowly. It's so great to see you all. Pause. I was regrettably, I was only able to peripherally listen to a doozy of a case yesterday presented by the one and only Anne-Marie Comfort, which involved I don't even know where to begin. Basically, the summary is intrapartum immunosuppression renal abscess culture negative. And I wanted to share with you a bias. This is not a social bias. It is a diagnostic bias. We in the microlab are set up to detect what's called typical bacteria. And I think about that for a second. We call bacteria typical and atypical. We are so judgy. You think about that? You know how much of a judgment that is? Where you're like, oh, look at this bacteria, it's so typical. And look at this bacteria, it's so atypical. Ugh. You know, it's so uncool. Don't do that. Except when it's helpful to you and helpful to your patients, you can be judgmental, but only from a philosophical perspective, should you not be. So rule number one, lesson number one, don't be judgy. Don't judge people. Don't judge bacteria. But there's a reason we classify bacteria as typical and atypical. It's because the typical bacteria are easy to identify on gram stain and very easy to identify on culture. That's the fundamental distinction. Atypical is just frustrating. And frustrating because they don't show up on culture, frustrating because they cause clinical syndromes that are hard to diagnose. So let's take a deep dive into the atypical bacteria. And I put atypical in quotes because I know it's a helpful use frame, but over time, the CP solvers community will change this word into a more understanding bacteria. So what are they? 2 R's, 1 S, and 2 G's. RRSGG. I'll come up with a better mnemonic, but this is, forgive us for this working framework. By the way, do we have anybody yet? Because it would be so sad. Oh,
yeah.
All this work hours, still no volunteers. Life is so hard. So hard. RRSGG. There are a lot of non-culturable bacteria that come from the respiratory tract. Prominent examples are Legionella, Chlamydia, and Mycoplasma. Rickettsia are very, very hard to culture, and they are divided into the Ehrlichia group, the Rickettsia group, and the typhus group. Spirochetes are very, very hard to culture. Granulomatous diseases are very, very hard to culture, and I'll tell you more about these in a second. What do the atypical bacteria share? Why are they fundamentally hard to culture? It's because they don't live on your body. All these bacteria come from the world. Legionella comes from water. Chlamydia comes from birds. Rickettsia comes from ticks and mites and fleas. Granulomas come from the world in all shapes or forms. And there's some exogenous organisms that are close enough to bacteria in your body, but aren't quite like them. And these are things like Strep suis, which is a streptococcal organism that Han taught us about, and Vibrio vulnificus, which is a exogenous gram-negative rod. So what's the moral of the spiel? The moral of the spiel is my secret goal is to guilt trip all of you into volunteering to discuss. Behind that curtain is a lesson that we are judgmental of many things. We are learning how to be more kind and less judgmental about other people, but it's amazing how that kind of mindset gets into how we classify organisms, typical and atypical. So let's be less judgy of bacteria. They're not atypical. All they are is just hard to culture. Why are they hard to culture? It's because they don't usually come from your body. They come from the world, and they're not adapted to be cultured and grown in the medium that we're used to. Where could they come from? Well, they could come from the air or water and colonize your respiratory tract. They could come in the form of rickettsial organisms, spirochetes, granulomatous diseases, and very rarely exogenous gram-positives or negatives. How does this have anything to do with yesterday's case? Well, I'll have you listen, because it turns out that yesterday involved a very, very hard to culture organism that is on the schema in very, very small font, hidden somewhere. I highly, highly recommend you listen to a fantastic discussion by the crew. And Anne-Marie also has a tutorial on this, which I will post in the chat in a moment. But in the meantime, I'll pass the mic back to Charmaine to rally the troops for another conversation today.
Thanks so much, friend. Always a pleasure listening to you talk medicine. We have a case from the one and only Alec, but we're still waiting for discussants. Anybody wants to volunteer and have fun, nerd out about medicine with us? I love Drew's like dot, dot, dot. Oh, thank you so much, Chen. We would love to discuss the case with you. Do you want to unmute yourself and introduce yourself?
Hi, everybody. My name is Chen. I'm from Israel. I just finished my medical school and I started my one-year internship. And hopefully I will get to start residency in internal medicine next year.
Hey, Khan, thank you so much for showing me how to pronounce your name as well. Thank you so much for joining us. We're so excited to have you. And I'm so glad you're going into internal medicine. More the merrier, if you ask me.
Yeah.
Anybody, Alec, do you want to say hi to everyone?
Sure. Hey, I'm Alec. I'm a first-year hospitalist at Baylor College of Medicine in Houston, and haven't been able to attend these as much as I would like, but I'm happy to be joining today.
Alec, I'm always very excited for your cases. So I'm like just really drinking my coffee really fast to get my brain enough caffeine to be able to keep up. Thanks, Alec. Anybody else wants to join Chen as a discussion? All right, that's okay. RG, should we just rock and roll? And Robbie, I still see your screen if you want to. There we go. Thanks. So if you can get the board up, then we can get started.
Hey, I'm Steve McKee. I'm happy to join and be another discussant.
Oh my gosh, Steve,
Yeah.
Thank you so much. Tell me a little bit about yourself.
Sure. I'm from Arkansas. I work at the VA most of the time and then do 6 weeks of hospitalist work at the Children's Hospital as well. So MedPeds hospitalist.
Oh my gosh, that's so awesome. Thank you so much for joining us, Steven. So
happy
excited.
to join.
So excited to chat with you all. Maria, if you don't mind sharing the board, we'll get right to it. And RG, the mic is yours.
Rock and roll.
All right. So today we have a 60-year-old man with neck swelling and shortness of breath. So He reports about 2 weeks of progressive shortness of breath and associated with a dry cough with white sputum. And he also notes some subjective fevers, hasn't measured his temperature though, some chills, weight loss, and really over the last week, some what he describes as neck growth and swelling. But he denies any GI or GU symptoms, nausea, vomiting, or really anything else. And that's, I think, the first outcome information I'll give you.
Awesome. Thank you so much, Alec. I got to tell you, every time you present a case, I get a little bit of, it used to be palpitations, but now it's like subtle sinus tachycardia, but a lot of excitement and gratitude, really. It's not easy to put all this together and present it as effortlessly as you always do. So thank you. Once I hear the word VA, I can't move past it. I would love to go discuss this case with you, Steve, if that's okay. And maybe you could just kick us off with where your head is at with this information. I'd love to learn from it.
Yeah, absolutely. Happy to. So I like to use the semantic qualifiers like you guys do to sort of reframe this and get started. So what I'm hearing is a middle-aged man with a subacute shortness of breath and the hallmarks of an inflammatory condition. The couple of things that stood out to me were, obviously we can think about the triad that you guys talk about a lot of dyspnea and shortness of breath being heart, lungs, and blood. But then the things that don't really fit with the 2-week time course are some of the more constitutional symptoms. So the way that my brain's sort of jumping around, is this a process that is really only been going on for 2 weeks and is involving both the neck and the lungs or the heart? Or is this maybe a more chronic process that has involved the lungs and has now become more acute? So is this sort of an acute on chronic picture, or just sort of a worsening over the past 2 weeks? So that's sort of how I think about it. I also like to approach cases. I think this comes from being med peds, but I like to approach cases in terms of what's going to kill the person or what can make them really sick in the next 24 hours. I can't remember everything in medicine or pediatrics, but the things that I need to diagnose quickly are the things I try to focus on, especially as a hospitalist. So any impingement on the airway would have me concerned, especially given the neck and the shortness of breath, as well as infections that we would need to start workup and antibiotics for. Those kind of things are pretty high up on the list. You have a little bit more time to diagnose indolent things like TB or some of the atypical, if we're being judgmental, bacteria. But that's sort of where my head is at. I would want to make sure that we've got a little bit more history and information about the airway and sort of the throat and neck area, and then consider starting treatment quickly for the things that could make him more sick.
I couldn't agree more. I love that. I love the translation into inflammation using the center of gravity of dyspnea, the neck pain. I think that's a masterclass and stands out on its own. So I will continue to eat my yogurt and pass the mic to Alec.
All right, awesome. So for a little bit more info, there's a past medical history of hypertension and diabetes, no surgical history, and only takes metformin at home, no supplements or anything else. Family history, he denies any family history of malignancy or really anything else. And social history wise, he's got a 10-pack year smoking history, quit about 10 years ago, and denies any alcohol or illicit drug use. And he's originally from Mexico, but has been living in the US for about the last 20 years. And he worked in construction. And this in Texas, not in Colorado. I can stop there, or I can give you the initial vitals and exam, whatever you would prefer.
How about we'll take the exam too, if you don't mind.
Sure. So vitals wise, temperature was 38 degrees Celsius. Blood pressure was 160 over 80. Heart rate of 130. Respiratory rate of 20. Saturating 96% on room air. In regards to his exam, he was alert, no acute distress. His mucous membrane moist, there wasn't any erythema or exudate. He did have a little subungual pallor. And then his neck exam, he had around a 4 centimeter mobile, non-tender, elliptical shaped, what I thought was a lymph node in the right upper neck, without any overlying erythema or drainage. And for the exam, he started regular, no murmurs, rubs or gallops that I could appreciate. For the lung exam, distant breath sounds, particularly at the left base, no wheezes or rails, and I didn't percuss at the time. Can't speak much on that, but his abdominal exam was soft, non-tender, and up initially, but when I re-examined him, he did have some palpable splenomegaly. And then his neuro exam was pretty much non-focal. And the only other notable thing on exam is that he had another 3 centimeter mobile, non-tender, elliptical shaped lymph node, likely in the right groin. And I'll stop there.
Oof. Alec, you never disappoint, my friend. Ken, I'm so excited to discuss this case with you. Let's go back to kind of like some of the background information first. What are your thoughts?
I would like to start first of all with but I think it's wise to look at it as the approach to lymphadenopathy and to shortness of breath and try somehow to connect them. I think that mostly we try to separate lymphadenopathy into localized and generalized. And when we just started with the chief complaint, so I first thought about it as localized to the neck. And usually when we talk about the neck, we can separate it into anterior lymph nodes and posterior lymph nodes. And also I think it's important to think about the time course, such as acute and subacute, for example, or chronic. And I think he described that it developed during 2 weeks only, which is quite fast, I think, to think about lymphomas and all of that, although we cannot really rule it out. But it's quite quickly, I think. And so first of all, I think I would try to exclude some common infections, okay? Something like head and neck infections, EBV, CMV, toxoplasmosis, primary adenitis. I think it's more in children, but we can think about it. But I think 2 weeks, it may be some manifestation also of a subacute, something like TB or a non-tuberculous mycobacteria, which can do that also, Bartonella, and more rare things like tularemia or I don't know, Kikuchi, and some rare and faraway diagnosis. But once we know also about the lymph node in the groin with 3 centimeters, it's quite big. If I remember it correctly, in the groin, it can be up to 2 centimeters, which is the only place that it can be also physiological. Then we need to think about generalized lymphadenopathy and think also about leukemias and also about, again, infections, EBV, CMV, and all of that. In his history, I know that he used to smoke. That's what we said. And when he's 60 years old, we should think about lung cancer. But also, if we say neck, sometimes we know it's also connected to the supraclavicular nodes. So we know that supraclavicular lymph nodes are almost always pathological. And usually when we see the Virchow node in the left side, it means something from the abdomen, malignancy from the abdomen. In the right side, usually something from the mediastinum. But here it sounds less supraclavicular and more cervical. So that's it. And once I rule out infections and then malignancies, I think I would go to more rare stuff like autoimmune diseases, etc. That's basically.
That was so awesome, Ken. I loved your approach. I love thinking about both like the localized and then the generalized lymphadenopathy to inform what your thinking and the time course about, again, like infection being the one that we were most worried about, given the patient's presentation. However, once that is ruled out, then thinking about malignancy and other things that we're getting some signals for. So that was really, really fantastic. Just to layer on to your incredible discussion, I'm similarly, initially when this case started, I was like very much in the HBA focus on like, oh, so what are kind of like maybe some acute complications of like a sore throat, for example. So thinking about Lemierre's disease of some sort that can have like dramatic presentation with the thrombophlebitis, people can get quite sick. And as we get more information, especially on the exam, this patient is sick, right? He's febrile, he's tachycardia in the 130s. I'm worried about this. And as you mentioned, like with the generalized lymphadenopathy, we know with that fever that we're dealing with like something systemic, whether it started in the head and neck, now it involves the entire body. One thing that really captured my eyes was the palpable splenomegaly. And in my mind, that is like, again, like you can think about that as a giant lymph node, right? Again, that kind of layers on that generalized lymphadenopathy, whether what is going on in the spleen, is it filled with water, which tends to be the most common causes of splenomegaly, whether it's filled with cells, like your RBCs, your WBCs, or is it filled with molecules, which tends to be like less likely. And I think like whatever we decide, like it kind of has to explain the splenomegaly. And one thing that I always like keep in my mind is that whether an acute infection or something reveal the underlying pathology that has been going on for a while. Is this a case that someone who might have a heme malignancy of some sort and got an infection and accelerated the pathology that you're seeing, or complications of that? So I agree with you that in a patient like this, who is 60 years old, coming with like 2 weeks of a shortness of breath and a weight loss and a neck pain that is now febrile, tachycardic with generalized lymphadenopathy, I'm most worried about an infection. And once that infection is figured out in response to therapy, then I would worry about like an underlying, maybe something that is more immunocompromising. He has diabetes, but again, whether there is a malignancy going on, because this is pretty dramatic presentation. With that, I'll pass the mic to the amazing Alex.
All right, awesome job as always. So I'll give you some initial labs and imaging. So the complete metabolic panel, so the BMP and LFTs, troponin and lactic acid were all within normal ranges. I don't have the numbers, so I apologize. For the CBC, the white blood cell count was 15.9. The differential was neutrophil predominant. No eosinophilia or anything else. The hemoglobin was 8.2. And the platelets were 145. The MCV was 79, which is in our lab, 80 to 100 is normal. And the chest x-ray showed a moderate left pleural effusion with compressive atelectasis. An EKG demonstrated sinus tachycardia without any concerning ST or T-wave changes. And he had a hemoglobin A1C of 9.2 and had a urinalysis without hematuria, pyuria, or significant proteinuria. And just for a little bit more, he had a reticulocyte index of less than 2. Haptoglobin was normal. He had a ferritin of 316. Vitamin B12 and iron panel in reference ranges. The HIV was non-reactive. and had a peripheral smear without schistocytes, spherocytes, or other atypical cells. And I think I'll stop there.
Terrific. So intriguing. Steve, where are you at with this?
Yeah, this is a good one. There was a lot of good information in that last piece. So I'm going to back up a little bit and just try to put the pieces together. So obviously we have, like we talked about, a middle-aged gentleman coming in with dyspnea, clear signs of inflammation, and what seems like abnormalities in the hematologic sphere. So he's got the lymphadenopathy, he's got the enlarged spleen, like was so elegantly spoken about. And so the things that, and then one piece that really at least changes how I'm thinking, or maybe a pivot point for me, is the reticulocyte count being so low. So, if his reticulocyte count was high and his haptoglobin was low, then you'd be thinking more hemolytic anemia. And his anemia is impressive, but it's not, his hemoglobin is not 4, so maybe it's not that important of a piece. But the fact that he's underproducing in his bone marrow makes me think that there may be bone marrow involvement of some sort, whether that's a liquid malignancy that's now infiltrated his bone marrow, or whether that's an atypical infection, or a mycobacterial infection, or a fungus. Any of those certainly can involve all of the sites that we're already talking about. The pleural effusion is interesting, and certainly the liquid malignancies can do that. Lymphoma obviously can do that, but it also makes me want to think and make sure that we don't forget autoimmune processes that can also cause this, just because that's oftentimes a big piece of it. But I think we got a lot of good information there, and we haven't talked about an HIV test yet, but obviously that's something that we wouldn't want to forget to send. But I think at least at this point, I'm headed down the road of indolent infections, space occupying infections, liquid malignancies, and then sort of third, autoimmune diseases.
Dear friend, I'm right there hand in hand with you. I love that analysis. And I'm particularly intrigued, like when I get to sit back here and listen to people discuss what people choose to start off with. And I think, we talk about the HPI as the patient telling us a story. And I think when we're trying to make a diagnosis, we're trying to put together a story of what's going on here. And I think starting off by making it clear what you think is noise and pushing that to the side, and then build a case for what you think is signal, is how I ask learners to present. And I see that you're doing that so masterfully as an experienced clinician. You're like, yeah, I know I see this, but I'm gonna put it to the side. I see this, I'm gonna put it to the side, and then I'm gonna acknowledge everything else. And I'm just saying that out loud to really have people who are tuning in afterwards, who listen in real time, to pay attention to that. That's a mark of skill, to first tell people, actually, no, I'm not going to use this data, and I'm going to use this. And I think as attendings, that's as teachers, that's the part that I think our learners get a little bit frustrated. Like, wait, how do you know to ignore that? And I think you did such a masterful job of explaining, going through that arc for us here. I don't have much medical knowledge to add, or reflections to add, but I'm going to make a bold statement potentially. And I think that this patient cannot have cancer. And I think that is a going out on a limb, but it's a marriage of many different things that actually eliminate cancer altogether with very high certainty. So why? Charmaine said it from the get-go. She said a spleen is essentially a large lymph node, and that is a good formulation for splenomegaly. Incorporates that with 3 exceptions. The splenomegaly, in addition to the spleen being enlarged, in addition to being caused by anything that can enlarge a lymph node, is commonly enlarged by cirrhosis, which has nothing to do with lymphadenopathy. So spleen equals lymphadenopathy plus cirrhosis. But then there are 2 other things that commonly go to lymph nodes that almost never go to the spleen, and that is syphilis. So if you have syphilitic splenomegaly, please call me. I'm dying to find a case report. It's one of the few things that syphilis cannot do. The other thing that tends not to happen with spleens is solid cancers. So solid cancers go to the lymph nodes all the time, but splenomegaly from a solid tumor is also there are exceptions to that, but it's rare. So if you're trying to make an equation, spleen equals lymph node plus cirrhosis minus syphilis minus solid tumor. So the case for a solid tumor is weakened significantly by the presence of splenomegaly. Now, you could And so that's the solid part. What makes a liquid tumor less likely? Liquid tumors are uncommonly accompanied by a neutrophilic leukocytosis. It's very rare unless there is a superimposed disease process for lymphoma or leukemia to cause a neutrophilia. Now that you have to be open to the possibility that lymphoma and leukemia lead to an immunodeficiency, and then there's a superimposed infectious process. But the combination of splenomegaly, which favors liquid tumors, and neutrophilic leukocytosis, which favors solid tumors, eliminates the possibility of cancer. Now, I say eliminates in a way that anything can be eliminated in medicine, is that your focus should be on infection. And there you can start to reflect on, okay, well, what kind of infections? I think, Steve, you said it well, and I'm just going to repeat it. You're looking for, I forget what word you use, space. Occupy, you say space. What did you say, Steve? I forget. I really like the language that you use. I wanted to upload it myself.
Yeah, so I said space occupying lesions or space occupies, organisms or processes, and then indolent infections.
Absolutely. I'm right there with you. I think the spotlight is on that. And I think that's why cancer is a little bit less likely for the reasons I mentioned. So indolent infections or space occupying lesions. That's terminology I'm going to upload. Thank you so much. All right, Alex, back to you.
All right, awesome. So I'll give you CTPE next, and it showed no pulmonary emboli to the segmental level, a large left pleural effusion, and a small right pleural effusion, which causes compressive atelectasis, and notable thoracic lymphadenopathy. And then he had a thoracentesis of the left pleural effusion, and it demonstrated 2,375 white blood cells, and 49% were lymphocytes, and 41% were neutrophils. Then the rest were a mix of macrophages and monocytes, and then had 265,000 RBCs, and then the gram stain and culture, including bacterial, fungal, and AFB cultures, were all negative from the pleural fluid. The pleural fluid ADA was also normal, and then the total protein from the fluid was 3.8. And then the total protein in the serum was 5.2. And he also had 3 AFB sputums and cultures, which were negative. And then, I guess in the interest of time, I'll give you the CT abdomen, pelvis, and neck. Sorry, there's a lot of information here, Maria. So in regards to the abdomen and pelvis, showed marked splenomegaly with ill-defined hypodensities and scattered numerous sites of lymphadenopathy, basically throughout the abdomen, the retroperitoneum, and for the sake of time, basically all throughout his body. And then the CT of his neck showed multiple enlarged, solid, and necrotic lymph nodes throughout the bilateral neck and supraclavicular regions. And the largest was 3.8 centimeters in the right neck that was partially compressing the right internal jugular vein. And I will stop there.
Phew, what a case, Alec. Okay. To take it away, my friend. What are your thoughts about the additional imaging and the data that we got?
Okay, so there is so much information here, so I'll try. I will probably forget something, but just to add something to what Robbie said, that in 99% we don't see any solid tumors that actually metastasize to the spleen, but the only one that can do it is actually melanoma. Now, I don't know if the only one, I'm sorry, but if there is some metastasis to the spleen, it can be melanoma. And actually, what I remember from medical school is that one of my teachers told me that melanoma can metastasize everywhere, every time, and to every tissue and whatever. And so I don't know if here it's the case, but we should think about it. I mean, we cannot rule it out. Usually when we see some hypodensities in the spleen, usually the first thing that comes to my mind is some infarctions. And then I think about endocarditis, but I don't think it's the case here with all the clinical picture. And so probably it's not infarctions. It's probably some either metastasis from melanoma, but to be honest, I don't know if it's hypodense on CT. I guess so, but I'm not sure. But I think that still in my top differential diagnosis, it's still some infection. I thought especially about TB at the beginning, but still there are so many things here that that now I'm not sure, like the adenosine deaminase that is negative, but I know that it's not always positive in TB, and also the acid fast. It's quite hard to really get it. I think it has very low sensitivity from what I remember. So TB, I'm not sure, but I still think that we should. I thought about HIV at the beginning, but I cannot explain the hypodensities, and that's basically, yeah.
Yeah, no, I'm right there with you. I still think like infection tends to be likely. And thank you for reminding us of melanoma. That was such an impressive thoughts. And in terms of where do you go, I think the thoracentesis was helpful. I mean, exudative, as we kind of like suspected. And the thing about thoracentesis is that whenever things don't grow, or we send like cytology, sometimes I always like looking at the sensitivity and specificity, because like, hey, things can hide and we might not capture it. So I like that you still are thinking about TB despite the cultures being negative from the pleural fluid. And I agree with you. I think like, hey, TB can hide, TB can be sneaky, and we know we're dealing with something that is very sneaky here. And whenever I think of TB, I think of whatever TB can do, histo can do better. So I think like any of the indolent like fungal infections as well is something to think about, especially like with the necrotizing lymphadenopathy that we see here. The other like, viral infections like, CMV, EBV, in my mind, I haven't seen them do necrotizing lymphadenopathy. Somebody correct me if I'm wrong, please. So I think like going after one of those lymph nodes would be very helpful in terms of like maybe isolating, again, like something that maybe is not growing in our blood, right? But it's hiding in the tissue and causing all this form of all this pathology that we're seeing. It would be probably my next move at this point. Alec, back to you.
All right, great discussion. So Travis really wants the LDH. So the LDH was 296 with the upper limit of normal in our lab being 270. For a little bit more information, they attempted a fine needle aspiration and a core biopsy of the right cervical lymph node, but both of them were non-diagnostic with only necrotic debris being visualized. And he had an SPEP and a UPEP, which were without a monoclonal spike. He did have serum-free light chains with a free kappa light chain of 135, with normal being less than 19. The lambda light chains were within normal range. And the ratio of kappa to lambda was 17, with normal being less than 1.6 in our lab. And then had cytology of the left pleural fluid, which showed significantly increased number of lymphoid cells with a mixed population of CD3 positive T cells and CD20 positive B cells, and then had flow cytometry of the pleural fluid with a kappa restricted B cell population. And then the next aliquot will reveal the diagnosis.
Since I have lost all absolute credibility, I will mute myself and pass the mic to Steve.
So this may or may not be right, but I was tricked by a case that's very similar to this unfortunate case. The woman passed away, and the diagnosis was made on autopsy, where she had intravascular lymphoma. And it's one of the things that I have never forgotten, because I probably ran every test in the hospital twice while taking care of this woman, and stocked her chart for a long time. And the way you make the diagnosis is oftentimes either peripheral flow, if you're lucky enough, or biopsy of a tissue that it's invaded, if you're lucky enough. Or I think, but I'm probably making this number up, but like 50% or more of the diagnosis are made on autopsy. So that would be pretty high on my list at this point. I think we haven't ruled out infections either. There's some infections that you have to diagnose by serology. So, and other things that are hard to grow. So I totally agree with what you guys have said so far. So histoblasto, non-tuberculous mycobacterial, crypto, there's a lot of things that would Bartonella still sort of on the list. And, we haven't done an echo, and I don't think we're headed this direction, but when I see multiple sites of involvement, I think endocarditis, and certainly some of the culture negative endocarditis could cause this. Although with your restricted B cell line, it's a lot harder to make that argument. It's interesting that kappa lambda free light chain testing oftentimes think of multiple myeloma, but this doesn't look like multiple myeloma classically, at least at this point. We don't have a bone marrow biopsy, and but certainly that's what I would have thought of first, and I even wrote it down. And then you can get a lot of odd, free light change and sort of immunoglobulin changes with all sorts of infections, but this is looking more and more like a lymphoma of some sort. Yeah, with that, I'll mute myself.
I know, that was absolutely brilliant. I'm right there with you, and I love that analysis. And I think that we have all been humbled by really tough diagnoses to make, and using that as fuel to propel you never to miss it again is inspiring. And if you are still interested in anything that I have left to say, you would reflect on how nothing is perfect in medicine, and you always are constantly adjusting probabilities, and this data significantly swings the needle way back in the favor of malignancy. But you literally have proven that this person cannot make appropriate immunoglobulins with how skewed their kappa and lambda chains. So being open to a superimposed infection is crucial. But I think that the tension in this case is we often associate aberrant immunoglobulin secretion with multiple myeloma. But we know that multiple myeloma is typically a malignancy restricted to the bone with occasional extension into soft tissue, which we call a plasmacytoma. So how can a paraprotein-related process be mapped onto a process that invades the lymph nodes and has more soft tissue appearance? And that's when we commonly meet multiple myeloma's cousin, Waldenstrom's macroglobulinemia. But that is typically associated with an IgM monoclonal protein and not such aberrant free light chain excretion. So I think it's helpful to step back and be like, well, what are liquid tumors in general? And when we say liquid tumors, we divide them into leukemia and lymphoma. Here, the lymphoid cells are consistent with the lymphoma, and that's when we divide lymphomas into historically Hodgkin's and non-Hodgkin's, but more for the internist, I divide them into B cell and T cell lymphomas. And then within the B cell lymphomas are a subcategory of plasma cell related diseases, which are the most characteristic to secrete a paraprotein. And the three plasma cell diseases are multiple myeloma, multicentric Castleman's disease, and a plasma cell leukemia. So those are the ones that are classically associated with secretion of a paraprotein. Multiple myeloma, a multicentric Castleman's disease, and plasma cell leukemia are plasma cells that pump out this abnormal protein. Waldenstrom's, while certainly not compatible with a no MGN spike, is a great example of what's called a plasmacytic lymphoma. And there's this idea that as the B cell matures into a plasma cell, it gets stuck in this phase in the middle. And that phase is when it can act both like a B cell and invade the spleen, the liver, but actually also secrete a paraprotein. And so I think the case for lymphoma here is very strong, and it likely is a lymphoplasmacytic lymphoma that is caught in between the B cell to plasma cell change. Or Alec has a lot to teach us about variants of multiple myeloma that can do this, or this ends up being a pure plasma cell disorder like multicentric calciumins, which is notorious for being very necrotic, very aggressive, causing effusions, causing lymphadenopathy. But I will leave it at that. I will always be humbled and will tweak my own probability parameters and adjust how often I take neutrophilic leukocytosis to mean not liquid tumor unless there's a superimposed infection here. And we'll pass the mic to Charmine and Chen to see if they have anything to add before since we have a few minutes, before we pass the mic back to Ali.
Stephen and Robbie, that was fantastic. Chen, go ahead.
Yeah, so yeah, I think that also when we think about lymphoma now, when we get these parameters, so it's not so far away from what we thought, but still, I think I would want still to see the serologies for CMV, EBV, HIV, and all of that, still to rule it out. But of course, also to get some excisional biopsy of whatever lymph node I can. I think that also when we think back, so we didn't really get the full anamnesis. We didn't ask about if he traveled somewhere, if he had pets at home, anything like that. Because when we think about the necrotizing lymphadenopathy, we should think about things like Bartonella and tularemia and all of those. So I don't think it's the case, but it can be. Yeah, but that's what I would get, excisional biopsy probably.
Great thoughts, Chen. Yeah, the one thing that I was like kind of reflecting on was like time course, right? And often it's such an important part of diagnostic reasoning, and the story is different depending on where you started, right? Like for this patient, all these symptoms come at head at like 2 weeks ago, but it doesn't mean like underneath there was not something brewing for a longer time. So something to always reflect on and think about. Alec, I can't wait to hear the resolution and learn from you.
All right, awesome discussion, guys. So the excisional lymph node biopsy was next. It was done in the right groin, and got a good sample this time, and it demonstrated EBV positive diffuse large B-cell lymphoma. So, given his constellation of, diffuse lymphadenopathy and B symptoms, and, I tried to push him a little bit more about his time course, because the 2 weeks was not, that it was a little bit surprising. And then I was able to talk to his wife, and he had been losing weight for months. So I think it just got to the point where he couldn't really work anymore. And that's why he showed up to the hospital. But given everything, he was diagnosed with diffuse large B-cell lymphoma. He did get a bone marrow biopsy, which showed 15% involvement of atypical lymphoid cells with that restricted kappa population. And so he likely had bone marrow involvement of his lymphoma, which they felt explained some of his cytopenias. And he initiated our EPOC and some intrathecal chemo, and is currently doing pretty well. As far as the leukocytosis, the only thing infectious that he didn't have any travel exposure to pets or anything like that. He had stayed in Texas basically since he moved from Mexico. So we didn't actually send a very extensive infectious workup, and all the infectious studies from the samples that we took were all negative. Besides, he had one of the initial, like the fine needle aspiration had some strep, which ID thought was just a skin contaminant, not like a pathologic infection. So I didn't include it. And then, as far as the, the kappa restricted population. I tried to ask heme about it, and they just thought it was all related to the lymphoma. They didn't really seem to think too much about it. So I thought it was a good case, and I learned a lot from your discussion. So let me know if you have any questions at all.
Thank you so much, Alec, for presenting. I'm always just very impressed and humbled by your just thoroughness, thoughtfulness. Like, you're such a fantastic doctor, and we're so lucky to learn from you. So thank you for sharing all of this incredible learning. And damn, DLBCL always humbles me. I feel like I always get fooled by DLBCL, and something for me to always consider. I think in the past year, there's been like a couple of DLBCL cases that I'm like, oh, well, maybe lymphoma, but maybe atypical infection that turns out to be DLBCL. So this was like another great reminder of this disease. And Robbie, Chen, Stephen, any thoughts before we pass the mic to Sukriti? I'm so glad the patient is doing well. Thank you for the update.
I thought that was a really wonderful organization of the aliquots. We got all the right information that we needed and didn't get sort of off track too well. So thanks a lot. And thank you guys for organizing.
Yeah, I'm also really happy for the opportunity. I think that sometimes I try to watch VMR a lot, and always we have special cases. And I think that something in my mind also looked for something special, but sometimes we just need to rule out the more common things first. And even if the clinical picture doesn't exactly fit, but as you say, he said 2 weeks, but it's not necessarily really 2 weeks. It can be what he remembers actually to say. So thank you so much. It was really well organized.
Y'all, this is so much fun. We literally for like 55 minutes, nerded out, courtesy of our dear friend Alec, with everyone in the chat and our two guests in the lukewarm seat today. Like, I don't know how much more fun you can have in medicine. And, it's unfortunate that it's in the context of somebody being diagnosed with cancer, and that doesn't ever we don't ever lose sight of that. But like, this is what we're here to do. We're here to get better and better and learn more and more. And I certainly, before your eyes, learned a lot today, and I hope you all took away something from the case. And to take us back to the journey again, the master, Sukriti, take us home, please.
Thank you, Shan, Stephen, Alec, Rabi, and Sharmeen. So to summarize the case, we began with our chief complaints of neck swelling and shortness of breath. And Stephen taught us how to investigate these symptoms. He created a framework in which essentially had 4 pillars. The first being the fever and weight loss, which he translated to inflammation, the dyspnea, which he thought of in 3 buckets: the heart, the lungs, and the blood. The time course, which he thought of as either acute or chronic, or a progressive worsening of a chronic process. And the fourth was to think ahead of scenarios that could lead to that could lead to rapid decline of the patient. The fact that this patient could lead to an airway compromise, and that was something that was most concerning to him. The second part of our discussion revolved around collecting clues, and we framed the case as a systemic inflammatory syndrome with lymphadenopathy and splenomegaly that we received in the second aliquot in the form of the physical exam. And this helped us to prioritize 4 things: the indolent infection, space-occupying lesions, liquid malignancies, and autoimmune processes. How did we do this? So we broke this down into lymphadenopathy and how it could be either localized or generalized. Sharmeen taught us how a localized lymphadenopathy secondary to acute sore throat could lead to the clinical picture that we see here of a sick patient having a possible complication of Lemierre's. And the second was to consider a generalized lymphadenopathy. However, since the differential for this is very broad, we use the splenomegaly to make progress. And so we think of splenomegaly in three buckets: water, cells, and molecules. And Ravi taught us that the spleen can be essentially equated to lymphadenopathy plus cirrhosis. And then further thought of we could think of this further as lymphadenopathy without splenomegaly being equated to syphilis and solid tumors, with the exception of melanoma, as Shen taught us. So here we were building a case of infection and malignancy, and what helped us move away from malignancy was the neutrophilic leukocytosis, which would possibly favor a solid tumor and make liquid tumors less likely. And then as we received more information and progressed to the third part of our discussion, which was framing a hypothesis, we framed this as lymphadenopathy plus splenomegaly, and therefore prioritized infections such as TB and histo. And Charmaine taught us how it's important to consider the sensitivity and specificity of a test before ruling in or ruling out a diagnosis, something that we all, everyone here who's given step 1 or step 2 recently may appreciate the spin and snout mnemonics. High specificity rules in and high sensitivity rules out. And here the hard to culture TB or histo infection that was not caught on the thoracentesis could be found in the tissue. And so we were really thinking about the issue could be in the tissue. But something that really changed the whole case for all of us and was essentially the pivot point was the abnormal kappa lambda ratio and essentially the layering on of the paraprotein process to this lymphadenopathy and splenomegaly. And Rabi taught us that it's important to consider the full spectrum of diagnosis of a variant Ig secretion and not anchor on multiple myeloma too quickly. And he taught us that lymphoma could be thought of as B cell versus T cell. B cell further in 3 buckets: multiple myeloma, plasma cell leukemia, and multicentric Castleman's disease. And I think Charmaine's reflection in the end was really apt about the time course, where she thought of the time course as even a subacute time course can be further thought as either acute or chronic or versus a progressive worsening. And that essentially helped us diagnose the case.
So great. You're so brilliant, my friend. At least for me, I feel like you always make me sound so much better. Absolutely brilliant. Chen, Stephen, Alec, Robbie, always a pleasure. Thank you all so much for joining us. What a great start to my Thursday. So thank you for that. Have a wonderful day. Bye.